Good afternoon. My name is Ariel Avgar, and I'm the director of the ILR Center for Applied Research on Work at Cornell University. And I'm thrilled to welcome you to our CARO-sponsored webinar, The Costs of Caregiving in New York and Beyond. The Center for Applied Research on Work, CARO for short, was launched 2 years ago with the goal of serving as a hub for rigorous research related to labor, employment, and work that informs action by a broad array of audiences outside of academia: policymakers, practitioners, workers, and everyday people. Academia has often struggled with the link between theory and practice. Efforts to translate research into applied and useful tools and information have been mixed in terms of their efficacy. This is a significant problem since we're arguably living through a time in which the link between research and practice has never been more needed and never more important. Confronting the myriad of tectonic shifts facing workers, unions, and organizations, from the proliferation of AI-related technologies to the shift in how and where work is conducted, will require policies and practices that are capable of meeting this turbulent moment. And this is a challenge that we at CARO are doing our best to address. One of the areas in greatest need of rigorous research that informs action and policy is the care economy. As we will hear from our panelists today, the systems for delivering care, for funding care, and for supporting the care workforce in the United States are broken. As a society, we have come to rely on a vast care workforce dedicated to our patients and our family members, and yet we have not built the infrastructure, including employment systems, that can ensure that this increased reliance can be sustained. I want to give just a concrete example from an area that I study with colleagues at ILR, the Weill Cornell Medical School, and the Tech Campus. Our healthcare system, this is around home care work, our healthcare system has decided that caring for patients at home, when possible, is preferable to institutional care. We have made this a strategic priority and invested a great deal of resources into a system that advances aging in place. And yet, the very workforce charged with delivering on this important strategy of aging and healing in place, namely home care workers, is undervalued, underpaid, marginalized, and invisible, not to speak of unpaid and paid family caregivers. How do we align our priorities with policies, investments, and infrastructure that will allow us to deliver on the important objectives of providing good patient-centered care, supporting the complex care needs of those in the workforce and out of the workforce, and building and developing a skilled care workforce with good jobs? We view our role at CARO as helping to make these questions visible and to bring together academics and policymakers, advocates, workers, to try to make progress on achieving these goals. Today's webinar offers an opportunity to learn from colleagues who are thinking creatively and deeply about what is needed in order to fix our care economy foundation. We'll hear findings related to care itself and to the workforce providing it, and importantly, what it means for policy and action in the care economy space. Before I turn it over to our esteemed panel, I just want to do a few notes of thanks. First, a big thanks to Ann DeCecco for all the work that goes into planning and guiding these webinars, alongside all the work that she does at CARO generally. Thanks to Cassidy Stanley for the terrific logistical support. And many thanks to all those who have worked on the CARO Empire State Poll, which Zoe West, our first speaker, will talk about and present findings from today. The Empire State Poll is made possible by an amazing group of researchers at ILR who work to ensure that the poll provides meaningful insights on the experiences of workers and residents in New York State. A very big thanks again to our esteemed panelists, who I'll introduce now in the order of presentation. So up first, we'll hear from Zoe West, who is a senior researcher in the Worker Rights and Equity program at ILR Worker Institute. We will then hear from Jamie Worker, Senior Director of Policy and Research at Caring Across Generations. We will then hear from Veronica Faison, counsel with the Income, Security, and Childcare team at the National Women's Law Center. We'll then turn to Veronica's colleague, Kira Weber, Senior State Policy Analyst on the Childcare and Early Learning team, also at the National Women's Law Center. And finally, we will hear from Michael Kanukin, Health Policy Director with the Fiscal Policy Institute. Really looking forward to the presentations and to the discussion. And with that, I'll turn it over to Zoe to kick us off.
Thank you, Ariel. Good afternoon, everyone. So as a starting point for our discussion today, I'm going to be presenting some research findings about the strain of unpaid caregiving for New Yorkers. As Ariel mentioned, the research I'm presenting is based on survey data from the Empire State Poll, which is an annual survey administered by the ILR school here at Cornell across New York State. And faculty can submit questions on different topics related to labor and employment issues and other concerns. The 2024 poll was administered in August last year, surveying 2,686 respondents across New York State. So I'm going to start sharing a slideshow now. In August 2024, the Empire State Poll surveyed 2,686 respondents across New York State. The recruitment of survey respondents is also targeted to ensure that it's representative sample by New York State residents across age, race, and region, and then it gets weighted so that it can ensure it's even more representative across a range of demographics. The research I'm presenting today is written up in a brief that I published with my colleague, Michael Lenmark, who's our survey statistician at the Worker Institute, and we'll provide a link in the chat to that brief, which will have all the details. Now, before I dig into the data, I do want to just begin with the frame that Ariel already set, that we are and have been confronting a national crisis of care. And as I'm sure many of you on this call can attest, those who are caring for family and loved ones are straining under the weight of that caregiving, while at the same time, support for care remains unaffordable and difficult to access. On the other hand, there is a shortage of paid care workers who endure jobs that are difficult, devalued, and underpaid. Now, although this crisis came under the spotlight when it was exacerbated during the COVID-19 pandemic, these are long-standing systemic gaps that extend across multiple areas, including what we'll hear about today, childcare and long-term care for older adults and people with disabilities. So let's dive into the Empire State Poll data to have one snapshot of how this care crisis is affecting New Yorkers. So to start, many New Yorkers are providing care on a regular basis for children, for adult family members, and for friends and neighbors. Overall, about 30% of respondents were providing unpaid caregiving support, with over 1/3 of women and over 1/4 of men. People of color were overall more likely to be providing unpaid caregiving support than white respondents. And we also found that people with disabilities were more likely to be providing unpaid caregiving support. One note is that on this point, I'm actually looking to 2023 data from the Empire State Poll that our colleague Jen Brooks from the Youngtan Institute on Employment and Disability provided, because disability was not a variable in the 2024 data. So in 2023, over 39% of people with disabilities were providing unpaid caregiving, compared with 30% of people without disabilities. Childcare was the most common form of caregiving reported. You can see here 18.7% of respondents, followed by 13.7% caring for adult family members, 4.1% caring for friends or neighbors, and then 4.5% of respondents were sandwich caregivers who were caring for both children and adult family members. We found that women were significantly more likely to be caring for children than men. And when it comes to caring for adult family members, Black, Asian, and Hispanic Latina respondents were all more likely to be doing so than white respondents. Now I want to get into the impact of all this caregiving on New Yorkers. So more than 1/4 of respondents, almost 27%, said that their unpaid caregiving responsibilities made it difficult for them to maintain a job. This was most pronounced among Hispanic Latina respondents at almost 39%, and among Black respondents at almost 37%. When we consider race and gender together, we see a particularly acute impact on Hispanic Latina women at 46% and Black women at almost 40%. And we saw this impact across all forms of caregiving, with the highest percentage among those sandwich caregivers who are caring for both children and adult family members. So here you can see those percentages. We then asked caregivers whether their time spent doing unpaid caregiving had led to them to spend less time doing paid work over the past year. Overall, over 36% of respondents reported this, with women significantly more likely to report this at over 40% than men, who are still just over 30%. And again, this was reported at high rates across all forms of caregiving. And here the highest rate was for those caring only for children. People of color were significantly more likely to report this. And we have here nearly 50% of Hispanic Latina respondents and over 44% of Black respondents. When it comes to caregiving choices, agency is really important. And so some people, for example, might prefer to do more caregiving at home and less paid work. So we asked about the main reasons that they spent less time on paid work in order to do unpaid caregiving. Here we found that the top reason overall was that care was not affordable. Overall, almost 58% pointed to care being unaffordable as being a top reason. This was even more pronounced among those caring for children, which is what you see here in this chart, with almost 68% saying they spent less time doing paid work because care was not affordable. And you can see just over 35% said it was due to a personal preference. Among those caring for adults, on the other hand, 50% said it was due to a personal preference. Now, to start drawing the connection more explicitly to the accessibility and affordability of support from paid care workers, I want to bring in some other data points that we analyzed from the 2023 Empire State Poll here, which had different questions. So home care is a critical form of paid care support for aging adults and for people with disabilities. Nearly a third of all respondents, 29%, said that they or a loved one had tried at some point to get home care services. And among people with disabilities, this was 41%. Overall, when they were asked about the past year, over 22% of respondents had hired someone to provide care or cleaning services in their home. Among those respondents, people with disabilities were twice as likely to have hired someone to provide home care support. Now, to continue drawing this connection between the strain of unpaid caregiving and access to support from paid care workers, I want to jump to another set of questions from the 2023 poll about the weight of stress and burnout and unpaid caregiving on paid care workers. So this is also available in a data snapshot, and we'll share the link in the chat for that as well. So paid care workers made up over 1/3 of the working population of Empire State Poll respondents, and you can see some of the categories here. And I just want to briefly highlight a few data points in the time I have. First, on frequency of stress at work. It was high across the board for all workers in New York at 52%, which is probably not a surprise to many of you on the call. But it was particularly high, as you can see here, among in-home care workers, which includes home care workers and domestic workers, with 66% reporting medium or high frequency of stress on the job. When we asked about the sources of that stress, we found that in-home care workers were more likely to report low pay and difficult schedules. Healthcare, in-home, and facility workers all reported disrespect from employers, managers, and supervisors as a source of stress at higher levels than the general working population. And healthcare and facility care workers were nearly twice as likely as the general working population to report that feeling unsafe at work was a source of stress. And looking at the impact of this, care workers are also generally reported a greater impact of stress and burnout. 40% of care workers said job stress and/or burnout often or very often made it difficult to take care of themselves or to spend time with the people that they care about. And this was a particularly heavy impact on in-home care workers in this regard at 64%. And in addition to providing care as their paid work, care workers are also more likely to bear responsibility for unpaid caregiving in their personal lives. So here you can see at almost 55% versus 41% of the general working population. So overall, all of this data affirms that caregiving, both unpaid caregiving and access to paid care support, really remain a pressing concern for the really high number of New Yorkers who are caregivers for children and/or adults. And these caregivers widely reported the toll that it took on their ability to do paid work, with the highest costs reported by people of color and women. And the lack of affordable care support stands out as a significant barrier. So taken together with this and the findings about stress and burnout among care workers, it reinforces the urgency of policy responses that can recognize and support unpaid caregiving, can make care more affordable and accessible, and provide dignified pay and working conditions for caregiving jobs. Yet a range of recent changes enacted by the Trump administration threaten to sharply aggravate this crisis of care. And so I'm going to pass it to my fellow speakers who are going to really also more fully draw out the implications of these changes and the impact on access to care and care workers themselves. But I just want to note that such changes are likely to increase reliance on unpaid caregiving, intensifying this strain that families are already bearing. Thank you.
Thanks so much, Zoe. Appreciate that. Jamie, if we can turn it over to you to kick off a round of reactions and assessment of your own work.
Thank you so much. I really appreciate this opportunity, and also Zoe for the research that you presented as well. It is an untold story, the work of unpaid caregivers and the work of care in general that has gone undervalued for far too long. And it is also even with the additional cuts at the federal level, it's actually been care has long been undervalued for decades. And so a lot of the gains that we saw during the following the onset of the pandemic, were just sort of touched the surface, and were in and of itself responding to a crisis. And with the additional cuts at the federal level that we'll talk about, we are not only set back, but are also on this continued path of underinvesting in care when folks are relying on it more than ever, or counting on it more than ever. And folks are both continuing to live longer, and as Ariel noted already, prefer to live in age and home. And one of the other aspects of aging and disability care, of which home care is a key part, that I wanted to also touch on, is that it's also being able to live in your own home and community is also a civil and human right. So one of the biggest victories of the following and inspired from the civil rights movement was a victory that took place in 1999 when with the Olmstead decision. So then it was then that the Supreme Court ruled that the unjustified institutionalization of people with disabilities is actually a form of discrimination under the Americans with Disabilities Act, and it required states to provide services in the most integrated setting possible based on that person's preferences. And it affirmed the rights of people to be able to live in community rather than institutions. So just wanted to share that also as a framework for why it is that the rights that we and values that we recognize of older adults and people with disabilities, and why it's important that we value that. And one of the reasons that Medicaid plays such a central role, it is really the only game in town when it comes to paying for long-term care. For most folks, private insurance is either too expensive or doesn't fully cover the scope of care that's needed, and Medicare does not cover home care as well. And so that means that you must qualify for Medicaid under strict asset and income limits to be able to access home and community-based care. And a little bit about home and community-based care as well. It is it is the day-to-day services that support older adults and people with disabilities to be able to live and age in home. It also includes support for unpaid family caregivers too. So it's everything from assisting older adults and people with disabilities with eating and dressing, being able to use public transportation or getting to appointments, being able to have supports to be able to participate in the workplace, and assistance with communications, home modifications, which can also be supportive for both care recipients and unpaid caregivers as well, and also respite services and trainings for family caregivers. So all of those things are inclusive of home care or home and community-based care, and are supported by Medicaid. Um, and the the it is also the primary pair of the workforce as well. And that is those are the primary pieces that I wanted to touch on as it relates to Medicaid and its relationship to home and community-based care. With the additional cuts, so this past summer, a federal bill signed into law on July 4th cut more than $1 trillion to Medicaid, Medicare, and the Affordable Care Act. And that has really dire consequences for states who rely on federal dollars to be able to not only provide these services, but also a range of public services in the state. And with cuts to Medicaid, that means that there will be, when it comes to home care, these are the cuts that will be first on the chopping block, because under federal law, home care or home and community-based services are actually considered an optional service. Institutional care, such as nursing homes, are a required service, and but not home and community-based care. So when policymakers are faced with tough choices about decisions regarding how to balance their budgets, optional services like home and community-based care, where the majority of our long-term care dollars go, are first on the chopping block. And then we'll hear more about childcare from our colleagues at the National Women's Law Center as well. There's this, I also wanted to highlight the similar story that is also the case for childcare as well. So right now, federal and state funding really undervalue childcare. And that means families can't afford to pay for childcare. Childcare workers stay underpaid. And also providers, largely small businesses run by Black and brown women, all struggle to keep their doors open. And so rather than really valuing the true cost of care, what it takes to operate a culturally affirming program with adequate staff and resources, family sustaining wages and benefits for care workers, and also affordable, accessible care. Various cuts at the federal level that have started since the beginning of this year have also compromised childcare as well. And so if the federal government and state governments aren't investing enough in aging and disability care and childcare instead, who is paying for it? There's clearly someone paying for it, because it's both there's demand, but also a lot of care that continues to be provided. It's family caregivers who are providing that unpaid care, and also workers who experience the consequence of that by being underpaid. And in addition to what Zoe shared regarding some of the most recent data around unpaid caregiving in New York, wanted to add additional context too. There's over 2.2 million family caregivers who are currently filling in some of the gaps related to care, and produce nearly $40 billion in economic value. And this is just like getting at the surface, right? It doesn't include things like routine out-of-pocket costs, lost wages, the challenges that Zoe described in terms of barriers to maintaining employment. Um, and then, in closing, as I wrap up some of my own remarks, I wanted to um, also highlight some of the points that I think are important for us to consider moving forward. And that's, related to specifically being able to prioritize our public dollars for care. So, care is something that connects us all. Each of us will have to either have or, will provide care, um, and receive care at some point in our lives. And in addition to being the work that makes all other work possible, and we actually need more investments in care, not less. And so, as states are, as policymakers are, again, faced with difficult choices, there are choices there to be made to minimize the harm to families, and to support families who have been for some time struggling with the cost of care. And so that means things like, ending corporate loopholes and ensuring that the wealthiest and big corporations pay their fair share through progressive revenue solutions so that families can thrive. And really excited about the opportunities in New York, both on the to make sure that care is valued, and also that folks who are eligible for care and not receiving services do receive them now.
Thanks so much, Jamie, for the presentation. Veronica, can I turn it over to you?
Yes, you can. Hi, everybody. It's really good to be here, especially among panelists who I cite, I learn from. So let me share my screen, always the most nerve-wracking part. All right, so my name is Veronica Faison. I work as an attorney at the National Women's Law Center, focusing on issues related to direct care workers and access to home and community-based care. So I'm going to talk about the barriers that care workers face historically, but also the growing threats that they are facing in this current moment. So first, who exactly are direct care workers? As many folks have talked about, direct care workers provide long-term care or support in a variety of settings, including nursing homes and residential settings, but also particularly in the home, which, as a few panelists have pointed out, people prefer to receive care and support within their homes and communities where they are familiar and feel the most dignity. These workers nationally and especially in New York are overwhelmingly women of color. So we have 87% women, 77% people of color, and disproportionately immigrants. So in New York, this is about 58%. So as many other jobs that are predominantly tasked by women of color and immigrants, these jobs are incredibly important, are the backbone of our care system. But you don't see that exactly in their wages. This is an incredibly, frankly, exploited job. Caregiving, care work has historically been undervalued due to our history of slavery, our continuation of sexist and racist policies that basically say that care work is something that Black and brown women workers are supposed to do and not receive compensation, but also ascribes to this point that the people that receive care are not important, should not be invested in. And we see this in how direct care workers are paid now. So workers, workers get paid between $16 and $18 per hour, which is already relatively low, but we see that the prevalence of part-time hours also drive these earnings even lower. So many direct care workers are not offered full-time employment. This is especially true for home care workers. And we see this in the fact that home care workers have a low median annual income of just $21,000. So how do these low wages and other like poor job quality impact direct care workers? So because of this low wage and other issues pertaining to a lack of benefits, a lack of career advancement, over 40% of direct care workers rely on public benefits in some way. And 10% of these workers actually go without health insurance. So public benefits include things like SNAP and Medicaid, which we'll dive deeper into later. Ultimately, low wages impact care workers' ability to care for their families. As Zoe presented earlier, a lot of care workers, as all people, have responsibilities toward their families and their communities. So we have a third of direct care workers that live with children under 18. A quarter provide family caregiving for an older adult, like a parent or grandparent. Many of those caregivers are paying out of pocket for their caregiving expenses, on top of these low wages. And especially troubling, right, is that many direct care workers live in or near poverty. So in New York, this is about 1/3 of direct care workers that do this work that, again, is I'd say like the backbone of our society. Everyone receives care at some point or needs to. And ultimately, this creates precarity not only for direct care workers themselves, but also creates precarity for the people who need long-term care, because this low wage and poor job quality drives workers out of their jobs. So many people might have heard of the direct care worker shortage or crisis, in that there are not enough direct care workers to meet the needs of folks who need and deserve dignified care. However, this economic precarity drives really high turnover. We see this particularly in the home care workforce, where we have 80% yearly turnover. And these are jobs that are, again, super vital for people to navigate their lives through aging and disability. So let's talk about Medicaid. It's always the woman of the hour. And Medicaid has faced decades of underinvestment. But despite this underinvestment, millions of people across our country really rely on Medicaid to survive and get at least some of their healthcare needs met. And this includes direct care workers. Direct care workers are doubly reliant on Medicaid. So, number one, as the largest payer of long-term care, including home and community-based care and services, Medicaid ensures that these services can at least be somewhat affordable for people. And a large share of the money that goes to long-term care from Medicaid goes to support already low direct care worker wages. And direct care worker wages being so repressed is also a result of the decades of underinvestment in Medicaid. But also, because of these low wages, direct care workers also rely on Medicaid for insurance. This is especially true for women workers who aren't getting employer-based health coverage. So for women direct care workers under 65, we have almost a third, or 27% of direct care workers rely on Medicaid coverage. And we have a good percentage of those folks who actually go uninsured. So we have these workers that are super essential and relied upon in our healthcare system, whose ability to access health insurance has always been precarious. The recent threats and attacks on Medicaid only threatens to make this much, much worse. So many folks might be aware of the passage of HR 1/One Big Beautiful Bill, or whatever it's called. And within this bill, Congress has passed the largest cuts to Medicaid ever. So $1 trillion in healthcare cuts from all of us, from our families. And these cuts will be felt on everybody ultimately, and make it harder for people to survive and navigate really high healthcare costs. And direct care workers are a significant part of that population. So first, kind of to like repeat a bit that Jamie dived more deeply into, is that Medicaid is the primary funder of long-term care, HCBS. And so despite the fact that these services are not optional, they are coded as optional. And so when states face budget threats, which every state will, states can often turn to these so-called optional services to be the first things on the chopping block, putting direct care jobs at risk, who have already faced things like understaffing and things that drive those high turnover rates. The so-called work requirements within that are the soul of these Medicaid cuts are not really feasible for a lot of working people to navigate, especially working people who face inconsistent hours or scheduling issues or non-traditionally structured roles, which include a lot of direct care workers. In addition, and really importantly, is that a lot of aspects in HR 1 is explicitly anti-immigrant. And we see this in how the cuts to Medicaid and SNAP are spelled out, that explicitly limit immigrants' abilities to access Medicaid. And immigrants are a disproportionate portion of direct care workers. And as many of us know, immigrants workers already face outsized attacks to their communities, facing a lot of changing in statuses, deportation, state-sanctioned violence. And obviously this is going to affect every community, because immigrants are part of every community. And we see this explicitly in our care system. So yeah, so we'll talk a little bit about this later, but some of the things that we can do is ultimately support laws that demonstrate and make sure that direct care workers, and especially home care workers that are like the lowest paid portion of care workers, that they have a right to a living wage so that they can support their families as caregivers, and also support themselves as people that will also face aging and disability in the future. We can also challenge proposals that states might make to strip back investments in long-term care due to these budget shortfalls. The money cannot come at the expense of people living their lives with dignity. And thirdly, I think uplifting the importance of protecting immigrants and immigrant workers, because you can't just pull people out of the community and expect the remaining parts of the community to be okay and weather that storm. And we see that explicitly in our care system. So with that, thank you so much for listening. And I'm excited to hear more from everyone else.
Veronica, thanks so much for the presentation. We're going to turn it over to Kira. Just while Kira's getting set up, I'll just say our data on insurance, health insurance for home care workers, it matches yours. And there are over 2/3 of home care workers in the United States overall do not have employer-provided insurance. As you said, they might resort to publicly supported insurance. And I often, when I give this number, I talk about this number, the thought of individuals caring for patients, making sure that patients have what they need, not themselves insured through employer-provided health insurance, is a big, big problem and another indicator that our system is broken. We have received, I think, a couple of questions, but I encourage those who are attending today, if you have any questions for the panelists, we will do our very best to get done with presentations and discussion and leave enough time for your questions. And with that, I'll turn it over to Kira Weber.
Thank you. Good afternoon. I'm excited to join this really important panel about the cost of care today. So I'm Kira Weber. I'm a senior policy analyst on the National Women's Law Center's Childcare and Early Learning team. Our work is to advance childcare and early learning policy at the state level and build momentum for greater progress nationwide. So our vision of a childcare system is one where every family has access to affordable, high-quality childcare, and where people who provide that care receive adequate compensation that reflects the true value of the work they do. So if any of you work on childcare policy or you have young children yourselves, you know that is not the system we have right now. Childcare is expensive and difficult to find, especially for families with low incomes. And on the flip side, childcare workers, 93% of whom are women, and disproportionately immigrant women and women of color, earn poverty level wages for doing essential work that allows our economy to function and our communities to thrive. So I feel like I'm going to be repeating a lot of the same things you've already heard. I'll try to skim over some of those, but here's just like a quick national snapshot of our childcare workforce. There are about 2.2 million in the workforce, and their median wage for a full-time childcare worker is $15.41 per hour, or about $32,000 a year, making it one of the lowest paid occupations. And you know, of course, having that, it's hard for childcare educators to find housing, which is really important for family childcare providers or educators who live and work in their homes. For many reasons, they can't afford the high rate of mortgages, as you know. So as you've already heard, the decades of underinvestment have resulted in a childcare system that has left us with a workforce shortage. And childcare programs are struggling to attract and retain early educators, which leaves families struggling to find and afford care. But who can blame the workforce for leaving when they're not being able to survive on the wages that they make, and they can't often send their own children to childcare. So, like, why not find a better paying job with benefits and shorter hours, right? So, unfortunately, there is a workforce shortage, no problem, but I'm just going to quickly rewind us to COVID-19 pandemic, where we saw a shift in the way that society viewed the child care workforce. The essential role that these child care educators play in supporting families in the economy was recognized through the American Rescue Plan Act, or ARPA, and other federal pandemic relief funds, and provided a lifeline to many childcare programs and their educators. So states were able to stabilize the childcare system for the time being and offer more supports to providers. So, for instance, in Kansas, $53 million was used for workforce appreciation bonuses for full-time and part-time childcare employees. In Oregon, they allocated funds for a state-sponsored retirement plan for childcare workers, and in Nevada set up a childcare hub for new and existing childcare providers to receive assistance and navigate licensing and collaborating with industry peers. So basically, with all of the stabilization funds, states were able to get creative, and in doing so, they were able to support a range of purposes aimed at helping the childcare workforce, which in turn increased the workforce supply and helped out families. Unfortunately, these funds expired in 2023, And the childcare program started reporting worse staff shortages and childcare program closures. And some states were able to sustain funding for a little while longer or come up with other funds. Unfortunately, many weren't, and these new programs or initiatives were put on pause or stopped altogether. It doesn't end there. Things are, somewhat getting better. States are leading the way, and because we know that this doesn't have to be the way that the childcare works. So some states have been able to find dedicated funding streams that will help childcare programs and educators. So in California, they were able to form a union for family childcare providers. I believe around 60,000 family childcare providers, and that they recently just ratified their third contract, which has retirement and healthcare in it, and as well as continuing education and training funds. And then California, Connecticut, Colorado, and Nevada all have programs that help childcare workers secure housing for their programs and for living, and potentially even able to buy in the long term. And then we've hopefully all heard of the DC's Early Educator Pay Equity Fund, which increases compensation for early educators to parity the DC public school teachers relative to their role in education. Some of these things aren't perfect, as we know, with what's going on at the federal government and the reconciliation bill. States are having less funding come to them federally, and so they're having to make up from here and there. And we know that DC's Pay Educator Fund has taken some hits recently, but it's more important than ever for states to be able to find stable funding investments so that they can help the child care workforce stabilize long term. Just in closing, we know that that's going to take a lot of significant funds from the federal government, but also hoping that states can figure out ways to put funding streams together.
Great, thanks so much, Kira. Really appreciate the state analysis and the kind of in the midst of a broken system, pointing to some examples of creative thinking around how to address that. Hopefully we can discuss that a bit more in a moment, but first we'll round out today's presentation with Michael. Michael, can I turn it over to you?
Yes, thank you so much. Hi, my name is Michael Knukin. I'm the Health Policy Director at the Fiscal Policy Institute, where I study New York's Medicaid program, insurance coverage issues. Before that, I worked at SEIU Healthcare Pennsylvania, where I helped represent nursing home and home care workers. So I bring that sort of worker-focused and also state budget-focused perspective to this. And I'm going to talk a little bit today about the New York State's Medicaid home care program, which in many ways is a national leader in Medicaid home care, how that program has changed in recent years, how large it is, how it's going to be impacted by the reconciliation bill, and also I think because New York operates such a large home care program, it can serve as maybe a guide for advocates across the country in terms of what makes sense to push for and what doesn't. There's some negative examples here, so I'm going to just sort of talk about the program and where it's headed. So Medicaid provided home care, as several panelists have discussed, Medicaid is the main payer for home care. Medicare doesn't pay for home care. And so home care pays for, so the state budget pays for home care, and it's a really large and growing part of the state budget in many places, including, especially in New York. The home care budget has grown quite rapidly. And that's unsurprising because we have an aging population and because home care is fundamentally and intrinsically expensive to provide, right? An elderly person who needs care to bathe and use the bathroom needs, potentially 2 or 3 full-time equivalents of human care labor in order to remain at home. And even as that labor is criminally underpaid, even so, 2 full-time equivalents of workers is an expensive proposition. So the average long-term care enrollee in New York costs the state about $60,000 a year. And enrollment has grown, is about to hit 400,000 in New York. So it's an expensive program. This graph sort of shows the growth in home care enrollment and spending. So spending is the line graph, enrollment is the bars. In New York State since 2015, ignore the last bar, it's partial year data, and really describes a striking trend of growth, right? In part due to program changes we'll talk about, in part due to an aging population. We've seen spending on this program more than double over the past 10 years, which has caused it to be a huge source of political conflict and angst in New York, right? As this program grows to be of the same order of magnitude of state spending as the public education system, it's become a real flashpoint of conflict between the governor, the legislature, and advocates. There's been also a dramatic shift in delivery system models in New York State for paid Medicaid home care. They're specifically, and I'm sorry, the numbers on the left in this graph are in millions of dollars. So, 6,000 is 6 billion. There's been a significant shift from agency-provided care to consumer-directed care, where consumer-directed care is a care model where elderly and disabled people can select their own caregiver, and very often that caregiver is a family member or friend. And so what we've seen in the past 10 years in New York is a marked shift where a growing share of Medicaid home care is actually provided by friends and family. Relatedly, we've also in New York made progress on wages and benefits, although I want to emphasize that wages and benefits are still totally inadequate to make these good family supporting jobs. New York has a legal minimum wage and benefit for home care through a program called the Wage Parity Act, and which, by the way, I would say that's a fantastic model for every state. I think it's really important to set a wage floor in Medicaid home care, and home care agencies will often advocate for increased rates paid to the agency, but they will not advocate for making sure those rates go to workers, and they frequently don't. In New York, largely because of the work of unions and advocates, we have a wage floor, and we also have an additional required spend for benefits. And so I'm giving the numbers here for New York City agency model care, but other regions and care models follow a similar trajectory where in 2010, we instituted the wage floor as $10 an hour. Today, it's $19.10 an hour. And then there's an additional subsidy for benefits. And so what I just want to emphasize here is providing a lot more home care and paying workers, still not adequately, but quite a bit, has been very expensive for the state. And I think we as home care advocates really need to sort of settle into the idea that expanding an elder care entitlement is desirable, but it also costs a lot of money. I think there's a widespread advocate view that this is not true, that Medicaid home care replaces more expensive nursing home spending. And so states will actually save money if they expand their home care benefit. This has not been true in the experience of states like New York and California and Washington and Oregon that have expanded home care. What those states find is that when you expand Medicaid home care, a lot of people who would not go into a nursing home, who would suffer at home, at risk of their health, or would be cared for by a family member in an unwaged way, generating all of the stress and problems that Zoe talked about, go on Medicaid home care. And that's great, but it is not, it's a matter of the state sort of accepting that there is a social cost of care and taking it onto the state budget. It's not a matter of just replacing institutional care with HCBS. And so that increase in spending is a really important dynamic to trace. While some aspects of New York State's Medicaid home care program have not changed, right? Like there's still a felt crisis of access where people can't access care. There's still problems of, poverty, wages, and jobs. I do want to emphasize that the industry has changed a lot as it's expanded over the past 10 or 15 years. And its industrial structure, mechanisms of delivery have changed. Before 2011, Medicaid home care in New York was really dominated by nonprofit employers, many of them sort of with roots in Great Society employment programs, and those employers were largely unionized. Then in 2011, the states shifted to a managed care payment model, delivery model for Medicaid, and the industry went through a really dramatic change, which was, I would say mixed. There are a lot more people getting home care in New York now than there were in 2011, so it's a bigger industry. It's also an industry with many more for-profit middlemen, including home care agencies, including managed care companies, and it's much more fragmented and less unionized than it was 10 years ago. We may be seeing a change or a new bad thing that's different from the old bad thing today, because New York State's home care program, the consumer-directed model, has shifted from being provided by many fiscal intermediary employers to just one statewide, state-procured one. That was a very controversial change, and it's been managed very badly, but it does shift the dynamic on fragmentation. So now, thinking about the impacts of the recent reconciliation bill, which I'm trying to learn to call HR1 and not the One Big Beautiful Bill Act, but we're getting there. HR1 is going to have a massive impact on home care in New York. Not directly, not because it will directly change LTSS eligibility, it doesn't do that, but because all the other cuts that previous panelists have talked about will squeeze the state budget in a quite dramatic way. And that will squeeze home care, which is a very large and growing share of total Medicaid expenditure. That will push the state to look for ways to lower home care spending. And so the state is already moving to restrict eligibility, to increase the threshold at which you are disabled enough to count as needing home care. It's very unlikely to continue the sort of inadequate but robust wage growth we've seen over the past decade. The new single statewide FI and other changes to enrollment may just sort of decrease awareness of an ability to enroll in and remain enrolled in the program. So that's on the sort of state budget end, or the state LTSS end. The other impact is, as several people have said, many home care workers rely on public insurance, Medicaid, or here in New York, we have a program called the Essential Plan, for their health insurance. Many of of those folks are liable to lose health insurance because of Medicaid work requirements, and especially because of cuts to immigrant health care. And these jobs typically don't provide usable employer-sponsored health care. And so workers are reliant on those public benefits or they'll become uninsured. Sort of taking, so we're at a pivot point in the program, right? Where this reconciliation bill is going to have this impact. And so it strikes me as a good time to sort of take stock of the past 10 years and what we've learned about the politics and policy of home care in New York. And it's a mixed record. I would say, on the one hand, New York policymakers have been grudgingly willing to sort of pay the cost of a steadily growing enrollment and also wage rate in home care, which has, it's grown by billions and billions of dollars. So it's been a substantial investment over time. At the same time, policymakers have been willing to accept a large and growing number of for-profit insurance companies and private equity-backed home care agencies in the system, sort of getting a cut of that growing budget. There's been a substantial shift within the system to paid family caregiving. And as the system has grown, it's funny. It's like if you're in another state and you're looking at New York, you might be thinking, oh man, like they have more home care workers per capita than any other state in the country. They spend more money on it than any other state. Surely they are in a situation where if an elderly person needs home care, they can find a home caregiver. But as a matter of fact, we still talk here in New York about a crisis of Medicaid home care, where there's a lack of access, a lack of ability to find caregivers. And I think that speaks to the enormous quantity of unpaid care that's happening, and that the state has shifted some of that into paid care. But there's so much of it happening that even a very large state investment in sort of waging that work still doesn't come close to sort of saturating the level of need. And then, as Zoe pointed out, there's a continued burden of unpaid caregiving, right? So we have not saturated the need there. And so despite, by national standards, high spending, our home care system has not really provided great jobs for people. It has not provided easy access to home care, and it has not sort of finished relieving the burden of unpaid care. So for me, there's some sort of questions that get raised by this paradox. I wonder, for one thing, New York has addressed the problem of providing waged family caregiving by just sort of funneling family caregivers into the same sort of employment structure we have for non-family caregivers. I wonder if it would make more sense to think about different models for paid family care, right? Like it can be episodic, it can be, not a full-time job, but something that you always have to be looking out for. Programs to, instead of just waging this labor, providing some sort of subsidy that provides people with more flexibility might be interesting. I think also we need to think about whether home care does its job of sort of integrating the elderly and disabled into the community. Home care that is delivered one-on-one as an individual entitlement can be isolating, right? There is a question of whether if, as happens commonly in some parts of Brooklyn, you have a building where there are 5 homebound elderly people all living in different apartments, each with a Medicaid home care worker. Does it make more sense to provide a community space for that care? Does that shift the staffing ratio and expenditure? And does that also connect people more effectively to their communities? And that's really, I think Medicaid home care exists as an individual entitlement, and it's a critical individual entitlement. But thinking about home care policy through the lens of an individual entitlement doesn't necessarily make as much sense as thinking about how we create space in our communities for elder care that is, and for the elderly and for the disabled, that is, communal space is integrated, might involve simultaneously much better care and much and better jobs at a lower expenditure than the current model. Not as a replacement, of course, but as a supplement for this model.
Thanks so much, Michael. Really appreciated the discussion of different structures and models that we might think about. I found that really helpful. What I wanted to turn now, again, thanks to all the panelists for insightful presentations. Much of the presentations, although not all the presentations, painted a pretty bleak portrait of our existing system in quite a bit of detail in terms of working conditions, in terms of deficiencies, shortcomings, and so forth. And in the spirit of what we're trying to do at the Center for Applied Research on Work and sort of how do we get to action, how do we get to solutions, I wanted to maybe go back to the beginning of the lineup, maybe go back to Zoe, and if you had a magic wand, where are we going? And then what's the call to action? And if you'd like, you don't have to do this, but if you'd like to tell us a little bit specifically about what your organization, all the panelists are doing to sort of advance that call to action. So Zoe, if it's okay, I'll turn it back to you.
Sure, thank you. It was really great to hear everyone's talks. I feel like we all have a lot to say in all these different topics. And I think there were some also great examples and discussions of particular programs and particular models and directions. But I think one sort of overarching principle is about universal access to care, and I think it's difficult to speak about this in a moment when the federal reality is what it is, and it seems like unviable to think about increased federal investment in care. And so, of course, I know as Kira talked about some state level innovations that are happening, which are really critical to look to, and Michael talked about like also the particular models in New York State. But I think just holding that as a principle, this idea that care is a public good, is a social good. And I think some of what Michael, what you were sharing about the cost of it, that like, yes, it is important to actually recognize it should be a social good. It should be treated as a cost that we all want to be met and treated as a public good, because it's a public issue that demands a public solution. And so I think that kind of principle and how we weave that in and is obviously very complex as far as dealing with the funding aspects of it. But I think also thinking about that in terms of universality, in terms of like ability to access it, affordability, eligibility, and things like that, in enabling people to have more agency, because I think that's also a big thing. Like care is a really intimate relational aspect of our lives, and it's core to all our lives, but to have dignity for both care recipients and for care providers, I think that ability to choose and to have agency about when you would prefer to stay home to provide care, and have a program like CDPAP in New York that can pay a family caregiver, or if you would prefer to be able to work the hours that you are meant to work and be able to afford and access care at home. And so I think to reach that, it really requires centering workers and care recipients in how programs are designed and how these decisions are made. And at the moment, we really have a system that is often increasingly for profit. As Michael mentioned, increasingly you have investment, like private equity and other forms of financialization moving into the care economy really, really quickly. And so you have profit becoming one logic that's dictating care. And from the government, you have austerity and this idea that that we should like constantly be reducing the costs. So I'll pause there and pass it to others.
Yeah, so one of the models also that we are all have supported in the past and are currently working on in different states is a long-term care social insurance option that also includes home and community-based services. So in Washington State, they have the first and only long-term care social insurance program that sort of functions a little bit like Social Security. You pay into it, and after you become eligible, you're able to draw on all or partial, depending on how long you've invested into the program, some of those benefits to either hire a care provider or and hire a care provider, including a family member, to provide that care. And then it both, invests in the workforce and care that's needed while also relieving some of the pressure from Medicaid home and community-based services as well. And so in addition to, over the long term, thinking about solutions to strengthen Medicaid, I think we also need to make sure that we're reaching folks who aren't eligible and don't have to limit their work hours or lose like critical income in order to become eligible too. So, and broadly, we're calling on the federal government to and members in Congress to cancel cuts and ultimately invest in care that both prioritizes Medicaid and then includes solutions for care for those who aren't eligible for Medicaid, like a Medicare benefit that includes home care as well.
Thanks so much for that, Jamie. I wanted to ask you a question that I was going to also ask Kira, given the discussion of sort of different state solutions. Do we know if states are learning from one another across these different innovations? And if so, like how is that learning happening? You gave the example of Washington State. Kira, when we turn to you, maybe also a little bit on are these innovations across states being used to learn from one another? Jamie, does any of your work touch on that, or should I turn to Kira?
Yeah, so in New York, there was actually a long-term care bill that was introduced that mirrors not the current Washington state policy, including some of the lessons learned from the early years of the development of the Washington state WellCare's policy. And so I think, and some of that is happening a little bit organically and also because of how, people, including lawmakers themselves, also have this experience of needing to provide care to family members and, see how there are such, critical gaps that are left that, require public solutions too.
Thanks so much, Jamie. I know we have some policymakers on, some legislators and staffers. So hearing about sort of these different state solutions and how they might learn from one another, I think is excellent. Kira, can I turn it to you both for call for action and anything you want to say on sort of how can states learn from these creative, innovative experiments, at least attempts to solve some of the problems?
Yeah, absolutely. So just to go back to your last question, states are definitely learning from each other. And part of my team's job is to uplift things that are working or even things that aren't working within states so that they can learn and share. And we have an annual report that comes out every year. Hoping the next one will be out in December that shares 50 state summaries or 51, I guess, if you include DC, on what they've been able to do during their legislative sessions, whether it was through like administratively or through legislation. So that's just one thing that we like to share with all of the advocates that we know and policymakers as well. I think broadly, we are pushing the federal government for large investment with that uncertainty right now. We're also doing our best to help states find revenue or ways that they can create these new initiatives and programs, and that is often connecting them with each other. And additionally, we're just trying to change the narrative around universal childcare and people, their understanding of it. We have pre-K, so why not for younger children? Children aren't born at 3 or 4 years old.
Right. Thanks so much, Kira. Veronica, can I turn it to you both for a call to action and anything about lessons across different states?
Yeah, I mean, I think the folks on this panel have illustrated this really well, but I think ultimately shifting the narrative so that we can widely understand that care should be treated like a public good. It's not supposed to fall on individual families fighting for their lives to pay their care workers and figure out unpaid family caregiving and all those things. So I think when we're talking about what we want investment to look like, I do feel like that anchor is super important. I think another really important thing in how we're talking about the workforce is like recognizing that the workforce is also made up of family caregivers and people with children, and therefore are entitled to a living wage that reflects that. Um, and thirdly, I think too often when we talk about immigration and immigrant workers, we can talk about it in this way that like, this is why immigrants are important because they're important to this workforce shortage. And I think what is actually really important in sort of reclaiming the narrative is that, our communities rely on each other. And when you harm one person from the community, that's going to have a ripple effect on everyone. And I think that perspective on like why we value immigrants is not just for like their labor, right? It's for the fact that they're entwined with all of us. And so you cannot harm one person without disrupting how all of us care for each other. So yeah, so a lot of that reframing, a lot of just like huge investments into care, because as Zoe, Jamie, Kier, everyone has said, like uh, we all care for others, and we all are receiving care or have received care, and we deserve to live in a society that actually reflects that shared norm and understanding. So thank you.
Thanks, Veronica. And Michael, coming back to you, any calls to action? You've talked about some different models and structures, but anything in particular you think that advocates, policymakers should be doing?
Oh yeah. Oh, so many things. I mean, one thing I just emphasized for policymakers is, in care is human labor, and like when the state spends money on care, the money should go to the workers. If the state wants to pay someone to take care of their own aunt, it should not need to pay also an insurance company and a home care agency and the private equity owner of that home care agency. Structuring things so that like every dollar the state is spending, because it's expensive, 97 cents is going into the worker's pocket, is really, really important. Like one of the strange things about moving this care labor into the Medicaid budget is you get this sort of very medical model where like who's entitled to home care? It's people who have like some definable disease, disability, whatever. They get diagnosed with having that disease. They're disabled. They need care. If you're just a little wobbly on your feet, you don't have that disease. You don't need care. And that's like very not what it's like to get old, or not what it's like to care for aging parents, right? Like there is a full spectrum of disability and need for care, ranging from people who are completely dependent for basic activities, for getting out of bed, on caregivers, to your mother who's getting on in years and you want to make sure someone's checking in on her during the day, but and thinking in terms of that spectrum is really important. I think otherwise you get like a lot of the fraud conversation in Medicaid home care is about positions on that spectrum. It's about like, oh, is someone cheating and pretending to be disabled when really they're just a little wobbly on their feet? And that's a horrible conversation that has nothing to do with like serving people's needs. So that's, I think, an important sort of guide. Medicaid once before, after 1965, dumped a lot of money into elder care and created a brand new for-profit industry. It was the nursing home industry, and it was a catastrophe, and it was run by criminals from the 60s on, and it's still run by criminals. It's horrible. For-profit actors don't have a place in this system. It's very dangerous to entrust the care and also the state spending to for-profit actors. Driving them out is an important sort of goal of state policy, and it's hard to do, but it's also foundational. And then I want to say something a little spicy. Sorry, I know I've talked a long time, which is like, policymakers should consider whether employer-sponsored healthcare is a good model for this workforce. Employer-sponsored healthcare for a full-time worker costs on the order of $5 an hour. If your home care workforce in some state is making $15 an hour and they're all on Medicaid, plausibly they would rather have $5 an hour more in cash than employer-sponsored healthcare. So that's like right? Like you should think about keeping your Medicaid program strong or providing alternative social health care rather than trying to like sort of jam this workforce into the model of employer-sponsored healthcare. That's especially true because for-profit intermediaries often just steal the benefit money and provide fake benefits or whatever. You know, like we all understand at some level that employer-sponsored healthcare is a bad model, and we're cursed with it in the U.S. And with workforces that are fully paid by the state, we should like think about whether it's a policy approach we want to sort of double down on.
Fantastic. Thanks, Michael. This is a question from a long-term care researcher and family caregiver who appreciated the discussion of the panelists on family caregiving and that's gotten a lot of focus in our discussion, and comments that they also think we need to really amplify that paid care workers are family caregivers too, as was stated by a number of the presenters. And then the sort of comment, but I think we can pose this as a question from an organizing perspective. It would be helpful to build our base and also help us work together rather than pit paid and family caregivers against one another. And I've seen this a little bit in this work that there are a number of kind of both assumptions that we make about paid and unpaid caregiving, and then family caregivers, paid and unpaid. And I wonder if there are any comments from the panelists on how do we make sure we're working together rather than pitting different groups within this already broken system against one another?
I can jump in quickly. I really appreciate that comment or question. And I think there's a couple areas of this sort of need for having like a unifying narrative and a vision of solidarity. And I think one is named in the comment, right, that family caregivers, paid caregivers, there's an enormous amount of overlap. And right, we saw this in the Empire State poll results, that paid caregivers were disproportionately likely to also be doing unpaid caregiving at home. We also, like in research I've been doing with my colleague Yiren Zhang on the CDPAP program in New York, we also see that so many people who are doing paid family care through that program are also doing unpaid family care. You also have people who are they're working as a PCA or HHA, right? Like a kind of spectrum of care that is paid and unpaid. And that is a reality of so many people's lives. But the other aspect I wanted to just like bring into that conversation is the idea that access to care means lowering standards for care workers. And so like when we recently saw the DOL, the Department of Labor under the Trump administration, roll back federal minimum wage and overtime protections for like millions of home care workers, the justification they provided was that this will increase access to home care. And so I also want to sort of, I think everyone on this call is aware of this sort of like toxic narrative, but this idea that they should be pitted against each other and that access to care is only available by diminishing standards of paid care.
Thanks so much, Zoe. I wanted to, maybe this might be our last question, and if you want to answer the previous question, that's also fine, or any other comment as we come to a close. In this notion of kind of both solidarity and thinking about things not in a fragmented way. A lot of the discussion that we had on this panel demonstrated that the challenges that the different care economy workers are facing are very, very similar. The issues are very similar across childcare and home care and domestic care workers and so forth. And yet, from a policy perspective, it feels like, and correct me if I'm wrong, but it feels like we're tackling each one of these as a separate world unto itself. How do we adjust childcare? How do we get at home care? How do we get at domestic care work? It's somewhat a rhetorical question, but what are ways in which we can make sure that we're addressing these challenges in a coherent kind of approach across the different care economy workforce areas and not just each one individually? Again, we've heard a good cross-section of these. The challenges are similar, but the solutions seem very varied across the different groups.
So I think what this moment, offers an opportunity for us to consider is to do some really deep listening within communities across the state and around the country about how our policies that were, not exactly from the beginning designed to serve all of us, how can they, better actually meet the needs of people in ways that are responsive and accountable, and don't just get at that haphazard patchwork set of solutions, and also restores people's faith in the role of government in people's lives. And so it's not a direct answer, but I think it also sort of speaks to the failure of like our current policies now, both in terms of like public investment that fails to address the scope and scale of the costs of care, and then also, services that are inadequate and don't actually, allow families to receive care in ways that they would like to receive it too. And so, yeah, I think we need to hear from more folks around the country around like what they need and deliver on solutions that get to that.
Thanks so much, Jamie. I think we are at time, so we're going to have that as the final word. Just a great deal of appreciation to our panelists for the work that you're doing, for your presentations, for the insights. A big thanks for all of the attendees for joining us, and looking forward to seeing you in the third installment of this series on the Empire State Poll. Thank you all so much.